Now, welcome to segment 33 of the Falcon Physician Review series of Online Anatomy. This section we're going to discuss the external genitalia. We have the female bits and the male bits. And since we're in Texas for a lot of this, I thought it would be appropriate to look at the female reproductive tract because I see a lot of similarities, of course, with the Texas Longhorn. And the male bits remind me of one of my favorite Saturday Night Live skits with Christopher Farley and Patrick Swayze, who, of course, has passed on since then. Let's look at the external genitalia from this lithotomy position, and we can see the urogenital and anal triangles. In the male, we have a glans with a prepuce, body, and testicle. And then in the female, the glans is hiding underneath the prepuce or hood. We can also see the mons pubis, the labia majora, and the labia minora. And these are all in the urogenital triangle. Then there's the vaginal opening, which is going to be in the vestibule, that space which is between the labia minora. So what do we have in the urogenital triangle? We have the perineal membrane, the urethra, and the genitalia. In the anal triangle, we have the ischioanal fossa, the anal orifice, and that external anal sphincter. So the perineum in general is a diamond-shaped area described by the pubic symphysis, both ischial tuberosities, and the coccyx. There's an angle between the two triangles that form this diamond. The urogenital triangle hangs in between the legs in the area of the ischiopubic rami and a line joining the two ischial tuberosities. That is the area that contains the external genitalia and the distal urinary structures. The anal triangle, on the other hand, projects posteriorly and between the coccyx and the sacrotuberous ligaments and a line joining the ischial tuberosities. The contents of the anal triangle will be the anus with all the surrounding ischioanal fat of the ischioanal fossa, the pudendal nerve and its branches that will be coursing through this area as it comes around the sacral spine. And then we have the anus, which can be composed of the external anal sphincter muscle, and this is the area that will also be the site for anal fistulas and hemorrhoids. In the upright position, you can see the pelvic orientation with the plane of the pelvic inlet angling forward and superiorly, whereas the plane of the urogenital triangle, or perineal membrane as it's also known, and the plane of the anal triangle being at 90 degrees to one another. The pelvic diaphragm would sit inside of this, and the perineum would be outside of it, with the true pelvis being inside of it. Now let's discuss the female regions and the external genitalia. The vulva is organized so that it has an anterior commissure and a posterior commissure. The anterior commissure is more pointed, the posterior commissure is more blunted so that it has a general teardrop shape. Inside of this we have a labia minora, which will define the area between the labia minora, known as the vestibule. And inside the vestibule we have two openings, a urethral opening which is more anterior, and a vaginal opening which is more posterior. Coming from the labia minora is going to be a frenulum which will reach towards the glans clitoris. Over top of that there's another frenulum which will connect the labia minora to the prepuce, or the foreskin of the female. Oftentimes the prepuce will cover over the glands, making sensory stimulation of the glands more difficult in female than it is in the male. The labia majora are the component that would be the equivalent to the scrotum in the male, and that's known as the hair-bearing area. And the labia minora would be the equivalent in the male of that raphe that zippers up along the scrotum, and that is a non-hair-bearing area both in male and female. Notice how there's a vaginal opening which can be closed off due to hymen presence there. Now the hymen is not a consistent structure, but it's a structure that you may find in females that have not had sexual relations at that point. It is not an indicator of that at all, though, because a lot of times any hymen that was there could be broken during childhood activities. One of the more problematic variations, though, is going to be if the hymen is imperforate. That way, then, when the menstrual cycle starts in a female, there's no egress point for any of the sloughing off endometrial lining, and this can cause infections. Let's look now at the structures of the superficial pouch, which is indeed the external genitalia. The structures homologue between male and female are actually pretty similar. The difference being is the extension portions of the male are much larger, and there's a third dilated component of the penis that the females don't have. It dilates down just to a simple vein because the urethra is contained within it. In the male we have two erectile bodies, and in the female we have the same erectile bodies. Here's the homologues. First of all, we'll start with the perineal membrane, which is sitting in the subpubic arch. Both erectile tissues will be in the superficial pouch outside of that perineal membrane. Then there is a vestibule of the female called the bulb of the vestibule, and then there's a portion which attaches to that called the bulb of the penis. In the female, there's two separate portions because they never fuse together as they did in the male. And in the male, they fuse together and encompass the urethra. Here you can see the corpus spongiosum, which will dilate out at the distal end into the glans penis. The same is true of the corpus spongiosum in the female, which will come out and form the glans of the clitoris. Then there's a structure known as the crus of the penis and the crus of the clitoris. Those two legged structures will attach to the ischiopubic rami and be anchored to that position. During penile enlargement procedures, they actually peel that away from the ischiopubic ramus, and that gives the appearance of an elongated penis, but really has no functional extension to that other than to destabilize it away from the ischiopubic rami. Then we have another erectile body known as the corpus cavernosum, and the corpus cavernosa come up as part of the crus, and they will elongate into the shaft of both the clitoris and the penis. It's the corpora cavernosa that give most of the turgidity or rigidness to an erection of both male and female. Since the urethra passes through the corpus spongiosum of the male, you would not want that to become as turgid because it would close off the urethral canal and not allow an ejaculate to pass through it. Here you can see cross-sectional cuts through the penis, one longitudinal and one transverse, to show the equivalence of the different structures. So the two erectile bodies are going to be the corpus cavernosa. There's duplicated on either side, and then there's a single corpus spongiosum in which the urethra passes through. Notice how there's a perineal membrane, and the Cowper's glands are projecting from that deep pouch, and they're projecting their ducts into the urethra. In the cross-section, notice that the erectile tissues are ensheathed in several fascial coverings. There's the two corpora cavernosa with that deep central artery is going to be the continuation of the internal pudendal artery and can be affected by atherosclerotic diseases. Then there's going to be branches that will run more superficial than that, along with the deep dorsal veins and the superficial dorsal veins, and those will be bilateral. Then you can see the fascia encasing the deep vein, but not the superficial vein, is going to be the deep fascia of the penis, also known as Buck's fascia. The glans of the penis is the dilated distal end of the corpus spongiosum, and the urethra is reaching through that portion and is not as turgid or compressed during erection. Now let's look a little bit at the genital development. It's going to start around day 19, and it won't finish until the descent of the testis, at least, towards the end of the pregnancy, near day 260. In the first few weeks, there's going to be the setup of the intermediate mesoderm along with the urogenital system, which is developing both urinary and genital components. We have the primordial germ cells migrating into the posterior wall at the lateral and craniosacral folding on week 4. And then the gonadal ridge is going to develop as portions of the mesonephros starts to set up. In the male, at least, this is going to be used for the testis. And in the female, different components of this will be used to make the ovary. Now the coelomic epithelium is going to be used, and some of these mesonephric cords will form some of the sex cords. The prostate and seminal vesicles will start forming around week 7 because the male starts to differentiate before the female. And the female is a kind of default pathway, so at week 12, the female, if there's no input from the Y chromosome, will then start to differentiate without the influence of hormones or it seems without the genetic driving factors of the X chromosome. Week 28 through 38 is going to be involved with the descent of the testis through the abdominal wall and into the scrotum. So, here's a words portion of some of that. The 7th week is going to be an indifferent phase. Then the male will start to differentiate around then, but full differentiation will take place around the 12th through the 16th week. At the caudal end of the embryo, the urogenital membrane ruptures and the urogenital orifice has to be formed. And then there's going to be a cranial projection of that orifice that's going to start developing on the wall of the fetus, which is going to make the genital tubercle, and that will become the phallus. The lateral margins of the phallus are going to form the urethral or urogenital folds, and then the lateral component of that is going to be the laboscrotal swelling. Let's look at this in a few of these diagrams. First, we can see the genital tubercle and the cloacal membrane with the laterally oriented urogenital fold on the either side of the cloacal membrane, and outside of that you can see the laboscrotal swelling. In portion 2, the phallus starts to develop. The urogenital membrane starts to shrink because the other forms start to differentiate into more prominent structures, and then you have the formation of the anal membrane. So there's a separation of that cloacal membrane. Distally, you're going to have the urethral plate pushing up with this urogenital fold that begins to fold into it, and that urethral groove will then become the urethra. Now you can look right at this point and know that if the urethra does not push all the way in, there's going to be some opening somewhere along the urethral groove. As we go to stage 4, male and female differentiation starts to take place. And you can see that the glands of the male is going to look very similar to that of the female at this point. The difference being that the urethral groove will start to fuse shut in the male and encompass the urethra, whereas in the female it's going to remain open and make the vestibule region. In the next steps, you can start to see that the male will be encasing the urethra, and the penile raphe will fuse portions of the erectile tissues together, whereas in the female they'll stay separate, and there'll be a little orifice for the urethra and a separate orifice for the vaginal opening. This is the Netter pictures that show the same kind of development, except there's color coding going on. And he uses slightly different terms, but in some ways it's a little bit simpler. The whole area is called the genital tubercle, with a glans and a lateral buttress, which is going to be the urogenital groove and the urogenital folds, and then that lateral buttress is going to be forming the scrotum or the labia majora. At 10 weeks, they're going to start to diverge in their development, and you can start to see how the laboscrotal swellings will start to become more prominent along the sides of the lateral buttress, which will then start to form the different components of the scrotum, penile shaft, and the raphe that will fuse together. In the adult version, here you can see what the fates of those different components are. Some of the clinically relevant things that you'll want to think about as far as development of the genitalia would be a complete agenesis. Though it's rare, it really happens when the genital tubercle doesn't form at all. It's really going to be from inadequate mesenchymal ectodermal interactions around week 7, which is when this genital tubercle should be forming. We've talked a little bit about indifferent gonads. We'll talk a little bit more about hermaphroditism, a condition where the sex can't be determined from the external genitalia. There's really a couple different types of hermaphrodites. One would be because of the true hermaphrodite, which would have both male and female genitalia, and it would have an ovotestis. Having an actual ovary and a testis, or combination of the two as an ovotestis, is fairly rare. And it starts to happen because there's a division of one ovum, followed by the fertilization of each haploid ovum and a fusion of the two zygotes in early development. Alternatively, an ovum can be fertilized by 2 sperm, followed by a trisomic rescue in one or more of the daughter cells. If these 2 ova are fertilized by 2 sperm, occasionally they'll fuse to form a tetragametic chimera. And if one zygote is male and one zygote is female, they can fuse to have a true hermaphrodite. So in some ways, they will start with truly separate ovary and testis. It can sometimes be associated with a mutation in the SRY gene, in which they would be male, have a mutation, but start along the female pathway of development. A pseudohermaphrodite is more common and can be either male or female depending on the presence of either testis or ovary, though this may have nothing to do with their gender preferences. Though sex can often determine genetically, they have been problems with early gender reassignments, and now they're asked to wait until the gender preferences are a little bit clearer before they start doing any surgeries on these interventions. Here you can see a 6-year-old female that had congenital adrenal hyperplasia, and still you can see that the labia have fused close and the clitoris has been enlarged. And this is through autosomal recessive effects. We've talked about this before, and typically these are going to be a result of 21 hydroxylase deficiencies. And that's important to remember because this is something that's often tested, at least in the biochemical sense of why there's indifferent genitalia. That concludes our segment on the external genitalia.